You mentioned that you're taking progesterone, or oral micronized progesterone, which, by the way, standard of care, that is the standard of care, is the oral micronized version of it. Before we got started recording today, I think I said progestin, and you're like, there's never a time for progestin. So let's talk about the difference between oral progesterone and progestin, the difference between the two. And then I have questions about, are you taking it constantly? Are you cycling it with yourself? I have all those questions that I know that everybody wants to know as well. So let's first delineate between synthetic and not synthetic.
Absolutely. So oral micronized progesterone, or bioidentical progesterone, or, however, there's a lot of different ways to say it, it's still made in the lab. So just know that it's plant derived, but
they're not picking it in a field.
Exactly.
Yeah.
I mean, technically they are, it's plant derived, and then it's synthetically.
Okay. All right. You got me.
Okay.
Yep.
But it's not like coming from us, right? But it's body identical. Meaning that it's exactly how it looks, exactly molecular structure as the progesterone that we make inside of our body. So it's binding to the receptor sites that progesterone would be binding to throughout the body and throughout the brain, right? Progesterone is a neurosteroid as well, which is so profound. That's why when we start to lose progesterone, we see those initial symptoms that are not related to your menstrual cycle. And then progestins are a synthetic progesterone, and actually kind of look more like testosterone than they do look like progesterone. Progestins are what you're going to find in birth control. They're what you're going to find in the Mirena IUD. They're what you're going to find in some hormone replacement therapy. They were the hormone. They were what was used in the Women's Health Initiative, MPA. So progestins they don't have a lot of neuroprotection, and they definitely won't necessarily mitigate a lot of the neurological issues that women are struggling with in perimenopause. Now, your doctors don't always know the difference, because a lot of the languaging in research articles vacillate between progestins and progesterone. So doctors sometimes won't know that they are giving you a progestin-only medication. So it's really important when you are talking to your doctor about perimenopausal symptoms, and note that standard of care in the US is to give you birth control, is to give you progestins. Whether it's the mini pill or it's the IUD, that's a progestin, but they may tell you that they're giving you progesterone. So again, just the reason why I want to delineate or kind of distinguish between the two is that there's a lot of confusion even in the medical system, whether you're being given oral micronized progesterone, so the real deal, the real bioidentical progesterone, which is called Prometrium in the US, or you're being given a progestin.
Yeah. And the progestin we can go down the laundry list of downward spirals that can happen from progestin.
It's an endocrine disruptor.
Yes. It's an endocrine disruptor. We will often see lipids go awry. Mm-hmm. We'll see it gobble, it's almost like it gobbles up CoQ10, like all these different things.
It'll nutrient deplete you, vitamin B, magnesium. It messes with your microbiome, but particularly it also has side effects around mood and brain related issues. And so what I will see kind of if women, and often the reason why women are put on progestins is one, just perimenopause. Like, let's just get you on the pill. Let's get you on an antidepressant or an anti-anxiety medication and call it a day. And so, that's what doctors have been told to prescribe. So, but usually women want, there's still a possibility of pregnancy, at least throughout early perimenopause. It gets a little bit more challenging in late perimenopause, but it's kind of like knocking out multiple birds with one stone. Okay, well, you're not going to get pregnant, so here's contraception. It's going to manage what crawls up my skin is when they tell me I hear that it's going to regulate your period. I was like, you mean it's going to turn it off? So I always hear that. That's always it's going to regulate your period during perimenopause. No, it's not.
Define regulate.
Yeah, what does that mean?
Yeah,
You run your hormones when you're on a mini pill, like a progestin-only pill or a combination pill or the IUD, and they're not there. They're not going to show up on the labs because they're not there. That's the whole point of what contraception is. It's meant to shut off your ovulatory cycle, because that's what it is. It's an ovulatory cycle, right? And so women will still come in. Yes, maybe the heavy bleeding is being managed. The regular weird periods are being managed because, again, you shut it off. So that's definitely what's going to happen. But a lot of women will still experience a lot of brain-related symptoms. And so what may happen, what may be recommended after that or given to you is then like 100 milligrams of oral micronized progesterone. So now you're on a progestin and progesterone in perimenopause, where I'm really of the mindset of, I mean, if your cycles are so erratic and the bleeding is so out of control, I mean, an IUD, probably the lesser of the evils, is I get it. But if we're trying to manage the neuroendocrine transition, being on real progesterone, real bioidentical progesterone, I feel like is the real way to go.
Yeah, because that's when you're going to upregulate the GABA, like the
you're going to actually get the benefits.
Yeah.
The neuroprotection, the reducing inflammation. Yeah, upregulating GABA. Progesterone is phenomenal. It's very much brain food. Not as much as estradiol is. Like, she is literally Houston. She's the CEO of the brain. She's the master regulator. But we can't dismiss the benefits of progesterone on the brain as well.
And you mentioned 100 milligrams.
That's usually the standard dose. Yeah.
Standard dose. And then have you, just as a point of interest, a little bit of just coming back to the migraines for a moment, have you found that progesterone helps with the migraines? You probably might need a little bit more than 100.
Yeah, I know. I cycle mine. So I rhythmically cycle progesterone, mainly because I really need a little bit more progesterone than 100 milligrams. And what I was finding is if I maintain 200 to 300 milligrams of oral micronized progesterone all the way to the end of my cycle, I mean, kick me off a cliff. Because I would just go from 300 or 200 milligrams and then I would just plummet. Right. And so what I'll do is I usually the first 5 or 6 days of the luteal phase, I'm on 100 and then I go up to 2. And I really, again, around day 22 is, I could kill somebody. Like, I got rage. Like, it's not day 27 for me or day 26 or 5. It is 21 or 22. And so I have learned from my own chemistry, that's when I need to go up. And usually I'll go all the way up to 300 milligrams for a couple of days and then taper back down to 2. And then usually a couple of days prior to my period, I'm back down to 100 milligrams and then I stop, and that initiates my period. Now, I will say that there are days you ask me, do I work my calendar, my podcast calendar or work calendar around my cycle? And unfortunately, it doesn't work out that way. But if I see that I have a really heavy couple of days heading into my period, I will take progesterone for a couple more days. I'll let her I'll basically push my period out until I can get through those 2 days or whatever, how long it is. I usually never push it out longer than 2 days. And then I will stop taking the progesterone to initiate my period.
And I think you have the benefit of, so you're taking it from, let's say, the day you ovulate, which is somewhere around 12, 13, 14. If you ovulate, you're just taking,
I take it no matter what, but I am tracking whether I ovulate or not. And I'm not ovulating all the time.
Okay. Well, that's interesting to know. And then are you okay, this may be TMI and we can cut this out.
I'm down to share.
We can totally cut this out. Is it like cervical mucus that you're looking at? Are you looking at basal body temperature? How are you determining?
All of it. I'm looking at all of it. I think, again, the more data points, the better. So I'll know if I'm potentially that I've a better chance of ovulation with the cervical mucus. I'm like, all right, girl, look at that. And, and then, and then I'll be tracking my basal temperature as well. And if I see that little bump up, that half a degree, then I'm like, ooh, mama ovulated. And sometimes I can feel it. Yeah. And so, but here's the thing, I get the migraine either way, so most cycles I'll get the migraine, on day 13, day 14. I usually ovulate day 12. When you look at my cycle. So usually the day after quote unquote ovulation, whether I ovulate or not, I'm probably going to get the migraine, but it also signals when to start taking that progesterone. And let me tell you, she is a godsend for me. Progesterone will make or break my stress resilience, my irritability, my ability to be a great mom. I absolutely need to supplement with progesterone at this point in my perimenopausal journey.
That's fantastic. And there are some people that take progesterone all
the time
long.
Oh, yes. And throughout the day, you don't have to just take it at night. Mm-hmm. So sometimes if I'm really struggling, I'll take 100 milligrams during the day and then I'll take another 100 or 200 milligrams before bed.
And it doesn't make you sleepy.
100 milligrams usually won't do it. 200 will. So especially if we want to use it for sleep, you may find your doctor just gave you 100 because that's the standard dosage and it's just not cutting it. I say go up to 200 and see how you do, and see if that helps to initiate sleep because it is a sedative. But 100 usually no problem, especially if anxiety, anxiousness, panic attacks, that kind of stuff is coming up for you, especially in the luteal phase of your cycle, consider, breaking it apart, taking it, maybe take it in the morning if you find you're more anxious in the morning, or maybe in the afternoon, and then take it again at night. So you can play with it throughout the day to see how you do. Some women also use, like, they'll keep their oral micronized progesterone in the evening for the sleep aspect and really calming the system down. But they'll use a topical, like a cream or a serum, throughout the day to kind of just keep the edge off. So maybe you can get kind of creative with it.
These are really great tips. And I don't think we've actually ever talked about like the practical application of it like this on the show before. Yeah. So this is really awesome.